Good afternoon, everyone. Welcome again to the Family and Consumer Education Initiative for Borderline Personality Disorder. My name is Chris Palmer. I'm a psychiatrist here at McLean Hospital and an assistant professor of psychiatry at Harvard Medical School. And I'm the director for the Department of Postgraduate and Continuing Education. And on behalf of McLean Hospital and Harvard Medical School, it's my great pleasure to welcome all of you tonight. This webinar series is funded by a philanthropic gift from a family that has been affected by BPD. And so we really want to express our appreciation and gratitude to them for making this free webinar series possible. We really hope that this will bring the latest information to all of you to help you deal more effectively with borderline personality disorder, whether it affects you personally, or whether it affects a family member, or whether you're just a mental health clinician or an interested person who wants to help other people. Before we get started, I've got some logistical announcements to make. Right now, you should be seeing two separate screens. You should be seeing a slide with McLean Hospital and Harvard Medical School at the top, but you should also see a smaller box with my image. If for some reason you don't see both images, you should scroll up to the upper right-hand corner, and there you will see a box with 4 arrows pointing out in each corner. If you click on that box, it will minimize one of the screens and you'll get both screens. If going forward you're having trouble seeing the slides, or if you want to see a larger image of the person presenting, such as me or Dr. Zanarini in a little bit, you can click on that box and that will become your entire screen. Additionally, you should see a question and answer, Q&A box, in the lower right-hand field of your screen. And that is live and active right now, and we really encourage all of you to participate actively in this webinar. So if you have questions about any of the presentation material, please feel free to type in those questions right away. If you have questions about borderline personality disorder in general, or how to deal with specific symptoms, or how to deal with a family member, even if it's not related to the content of tonight's webinar, please feel free to type in those questions and we'll get to as many of those questions as we can. I want to let you all know that your email address and name will remain anonymous and confidential. So when you type in a question, other people will not be able to see it. And for this reason, we've muted all of your microphones. So we won't be able to hear any of you, even though you can hear us. And we do this to maintain everyone's confidentiality. In addition to the screens that I just mentioned, there are some web links on the bottom left-hand corner of your screen. We have a link to our website. We have a link for the registration for our March webinar, which is already scheduled. That webinar is going to be presented by Dr. Hollander, and he'll be speaking with us on self-injury. We also have 3 additional links below that. Many of you have asked us, where do I find a clinician? How do I find somebody who will treat borderline personality disorder or is trained in this? And the 3 additional links that are in that box below are valuable resources that really help pair families and patients with clinicians throughout the country. The Borderline Personality Disorder Resource Center in particular is really focused on pairing people with treatment in their area. So if you're really struggling to find help, then I would strongly recommend that you contact the Borderline Personality Disorder Resource Center or the other 2 as well. And so with that, it's my pleasure to introduce tonight's speaker, Dr. Mary Zanarini. Dr. Zanarini is a professor of psychology in the Department of Psychiatry here at Harvard Medical School, and she's also the director of the Laboratory for the Study of Adult Development. She has devoted her career to studying the epidemiology and phenomenology of borderline personality disorder. She was the first person to actually report an association of borderline personality disorder with a high frequency of reporting adverse childhood events. But her work has also shown that childhood sexual abuse is neither necessary nor sufficient for the diagnosis of borderline personality disorder. She is the principal investigator of two major government-funded studies. One of them is the study for adult development here at McLean Hospital, and that is in its 24th year and has longitudinally studied people with borderline personality disorder. And she will be speaking a lot more about that study in a little bit tonight, so I'm not going to elaborate more on that. But she's also the principal investigator of another study, which is looking at the effect of psychoeducation delivered over the internet. And the preliminary results, at least, strongly suggest that simply receiving psychoeducation over the internet can reduce symptoms and improve psychosocial functioning at 1 year. And we certainly hope these webinars serve a similar purpose, providing education and helping people suffering from borderline personality disorder and their families. So with that, it's my pleasure to welcome Dr. Mary Zanarini, and she will take it away from here.
Thank you, Chris. My topic tonight, as Chris mentioned, is the long-term course of borderline personality disorder. Now, borderline personality disorder, or BPD as it's commonly known, is now seen as a valid disorder, which was certainly not true when I began my career about 25 years ago. According to the criteria of Robbins and Gouset from 1970 and the other forerunners for our DSM system, BPD can be delimited from other psychiatric disorders. Something of its etiology, both environmental and biological, is known. It runs in families, and it has a complex but increasingly known course. And BPD is now recognized as a common disorder. About 2% of American adults meet criteria for BPD, and the range in studies is 1.6 to 5.9. It's about as common in the American population as bipolar I disorder, and more common than schizophrenia. Oops. Now, there's a continuum of borderline psychopathology. Some people with BPD recover spontaneously and are never patients. And some use non-intensive outpatient treatment and are never hospitalized. And I would suggest or guess or estimate that about 80% of people are in these first two categories. But others become severely ill and use large amounts of mental health services, including repeated inpatient stays. And the latter group has defined BPD for generations of clinicians who typically have some of their training in an inpatient setting. And until very recently, most research studies have focused on inpatient-level patients. This presentation today primarily deals with this type of severely ill patient. Now, the McLean Study of Adult Development, or MSAD, was the first NIMH-funded prospective study of the longitudinal course of BPD. We began with 362 McLean inpatients who were assessed during their index admission, which began at a time when McLean's average length of stay collapsed from 60 days to 6 days. And 8 waves of blind follow-up are complete: 2, 4, 6, 8, 10, 12, 14, and 16-year data. And the 18-year wave is 99% complete, the 20-year wave is over 97% complete, and the 22-year wave began in July of 2015. Our subjects were about 300 or 290 patients meeting DIB-R and DSM-3R criteria for BPD, and I'll explain what the DIB-R is in a minute. And 72 access to comparison subjects meeting DSM-3R criteria for another personality disorder, but neither study criteria set for BPD. And let me say that when we first began this study, and when we continued it during the index admission, all of the subjects looked very similar. The clinicians did not know patients well enough to really know what their diagnosis might be, but they were all young, unbelievably unhappy, and often very suicidal. Now, the DIB-R is a revised diagnostic interview for borderlines. John Gunderson developed the original diagnostic interview for borderlines, and he allowed me to revise it to discriminate borderline patients from people with other forms of personality disorders. And it covers 4 sectors of psychopathology, unlike the DSM. Dysphoric affect, disturbed cognition, impulsive behaviors, and troubled relationships. What makes it different is that someone has to have symptoms in each of these 4 domains of borderline psychopathology to get the borderline diagnosis. And it results in a somewhat smaller but much more homogeneous group of patients than the DSM criteria. You may often hear about DSM that there are 200 or more ways to meet BPD. Here, there really isn't. You have to be unhappy, have troubled thoughts, be somewhat impulsive, and have relationships that are painful and difficult for you. Now, of course, there were earlier studies of the course of borderline personality disorder, and I stood on the shoulders of these earlier investigators. Before we began, there were 17 small-scale prospective studies of the short-term course of BPD, typically lasting 1 to 7 years, and they typically found that patients were taken to find that patients with BPD do poorly in the short run. There were also 4 large-scale follow-back studies of the long-term course of BPD, Tom McLaughlin's Chestnut Lodge study, Michael Stone's New York State Psychiatric Institute study, Joel Paris's Jewish General Hospital study in Montreal, and Eric Plakin's study at Austin Riggs. And they found that patients with BPD do substantially better in the long run. But there were limitations on these earlier studies, and it's not going to be a point that I'll cover, but I'll just say that one of the amazing things about all these studies is that none of them were funded except by their home institution. There were no government monies, short-term, long-term, any term, and that these people actually went out and did this work pretty much on their own, supported perhaps by their home hospital. But the limitations were that they used chart review or clinical interviews to diagnose BPD rather than semi-structured interviews. They either had no comparison group or the use of less than optimal comparison subjects, such as persons with schizophrenia. They relied on small-sized samples with high attrition rates. They used only very basic data was collected at baseline and follow-up, sometimes only 2 to 3 variables at each time point. Typically, there was only 1 post-baseline reassessment, non-blind post-baseline assessments, and variable numbers of years in follow-up in the same study. One study actually followed people up, the best of these studies, anywhere from 2 to 32 years. Now, our retention at 16-year follow-up, we're still following 88% of surviving patients with BPD and 83% of surviving Axis II comparison subjects. And I think these high attrition rates are due to the fact that, first of all, that I had phenomenal research assistants. Secondly, I think when borderline patients make a commitment, although they're very good at saying no, when they make a commitment, they live it out. And it's really been an honor and a pleasure to work with these people over this long period of time. And the third reason I think we have this high retention rate has been the fact that everyone calls into my office number, which has not changed, and until recently, my voicemail message had not changed. So there was a real stability in terms of who they were contacting. It was one central person who was very knowledgeable about them and very eager to hear from them. Now let's talk about symptomatic remissions. This is one of the really good findings of this study in terms of the course of BPD, which unfairly had a reputation as being a chronic disorder. If you once had BPD, you always had BPD, which is simply not true. Symptomatic remissions are both common and relatively stable, and remission is defined as no longer meeting either criteria set for BPD, DIBR or DSM-3R. Fully 99% of people achieved at least a 2-year remission, 95% achieved a 4-year remission, 90% achieved a 6-year remission, and 78% achieved an 8-year remission. If we had these kinds of rates for major depression, it would be on the front page of the New York Times. But BPD doesn't get that kind of publicity. But this is a remarkable rate of remission that for at least 2 years, almost every single person in the study with BPD fell way below our diagnostic threshold. They may have had some symptoms as we studied 24, not the 9 of DSM, but this is still a remarkable achievement. In terms of recurrences, they're relatively rare, far rarer than you would ever find in a mood disorder. After remissions lasting 2 years, 36% of the people, or about a third, had a recurrence. After remissions lasting 4 years, about 25% or a quarter had a recurrence. After remissions lasting 6 years, about 20% had a recurrence. And after remissions lasting 8 years, only 10% had a recurrence. Again, a very, very different picture than mood disorders. Now, completed suicide, 4.5% of borderline patients have committed suicide during the 16 years of follow-up. And this is substantially less than the 9 to 10% found in two of the 3 follow-back studies conducted in the 1980s that assessed this outcome. Why this enormous difference? Treatments may be more appropriately supportive rather than psychodynamic and exploratory. And most clinicians are sensitive to the idea of childhood adversity and not pushing people quite so hard. Now, there's another study that I was involved in that John Gunderson and other people were also involved in. The Collaborative Longitudinal Personality Disorders Study, or CLPS, was also NIMH funded. It began 4 years after MSAD, and it's now finished after following subjects for 10 years, and basically it had the very, very similar symptomatic findings. So our results have been replicated. Now let's talk about the complex model of borderline psychopathology that we've developed over time. We suggest that a hyperbolic temperament is the outward face of the neurobiological dimensions that underlie borderline psychopathology. And you might say, what's a hyperbolic temperament? A hyperbolic temperament is that people with BPD often have an insistent and persistent need for other people to acknowledge the enormous inner pain that they're suffering from. And one of the problems with this is they're often not direct. They don't ask for help as much as perhaps show people by doing things such as self-harming that don't immediately elicit the support that they actually need. After a kindling event of some kind, acute and temperamental symptoms develop, and kindling simply means an event. And the event can be normative, such as going off to college, and it can be traumatic, such as date rape. Now, what are acute symptoms? We found that breaking the symptoms of BPD down into 2 separate types actually will help clinicians treating borderline patients. And we've defined acute symptoms as they resolve relatively quickly. They're the best markers for the disorder as they're the most colorful symptoms. They're often the main reason for expensive forms of psychiatric care, such as inpatient stays, and they're akin to the positive symptoms of schizophrenia. They're what stand out for people about borderline patients. Temperamental symptoms, in contrast, resolve relatively slowly. They're not specific to BPD. Many of us have 1 or 2 of these symptoms. They are associated with ongoing psychosocial impairment, and they're akin to the negative symptoms of schizophrenia. They're what's left behind after the acute symptoms have resolved. Let's give examples of this. Acute symptoms examples would be self-harm or self-mutilation, suicide efforts, which are often help-seeking in nature, quasi-psychotic thoughts, meaning someone may have transient delusions or hallucinations, but they're somewhat reality-based and they respond best to structure, not to medication. Temperamental symptoms, examples would be feeling angry, acting angry a lot of the time and quite intensely, distrust and suspiciousness, although of non-psychotic proportions, and abandonment concerns, being very afraid that when those one loves and on whom one's dependent might leave and you would be left alone. Now let's look at this figure. This is an example of time to remission of chronic anger, which is a temperamental symptom, and self-harm, which is an acute symptom. And as you can see, everybody in this analysis started out with these symptoms. They both went down dramatically, but anger is still experienced by over 40% of the people. And it looks like about 5% of people were still self-harming. As another example, intolerance of aloneness, time to remission of this. Time to aloneness is a temperamental symptom, and suicide efforts is a acute symptom, and here it's the same picture. They both went down dramatically, but suicide efforts almost disappeared. Now, the course of the 24 symptoms we studied, we used two different methods of defining acute and temperamental symptoms among borderline patients, and symmetrically, and we're grateful for this, 12 symptoms were found to be acute in nature, and 12 symptoms were found to be temperamental in nature. Now let's go over these. You may say, oh, who cares about this list of symptoms? Actually, I think all of you should, whether you're a patient, whether you're a family member, whether you're a clinician, because these can help you guide treatment. Because the way it is now, nobody highlights for you what are the important symptoms. Again, these symptoms resolve relatively rapidly, and none of these patients had an evidence-based treatment. Among the affective symptoms, only affective stability was found to be acute in nature. Among cognitive symptoms, quasi-psychotic thought, which we've already talked about, and serious identity disturbance, which we put as a cognitive symptom because it's based on overvalued ideas of personal and inner worthlessness and badness, which is simply unwarranted. Impulsive symptoms that are acute in nature, substance abuse, promiscuity, self-harm, suicide efforts. Now, other acute symptoms that are interpersonal in nature are the dramatic symptoms of BPD, and they're also the symptoms that can get family members and treaters somewhat riled up. Having stormy or turbulent relationships, being devaluative, manipulating people. Sadism is just an unfortunate word for being controlling, being demanding or entitled. Having a serious treatment regression. For some people, treatment for BPD is actually toxic, and people get much more ill quite rapidly and start doing things they've never done before. And countertransference problems or special treatment relationships, and by that I mean a therapist whose countertransference problem would be a therapist who's overly loving or can become punitive. And a special treatment relationship can be something that evolves either into a friendship or, most unfortunately, into a love affair. Now, the temperamental symptoms, almost all the affective symptoms are temperamental in nature. Being depressed, feeling helpless, hopeless, worthless, being very angry, being very anxious, feeling lonely or empty a lot of the time. In terms of cognitive symptoms, as we've talked about before, odd thought, overvalued ideas, personal badness, for example, unusual perceptual experiences, for example, depersonalization, which simply means feeling unreal, or your realization feeling that the world's unreal, and non-delusional paranoia. Now, impulsive symptoms that are temperamental in nature is everything we haven't already mentioned. And that would be, for example, eating binges, spending sprees, reckless driving. And here are the quieter interpersonal symptoms for which therapists are often grateful, but which may not signal a good outcome. Intolerance of aloneness, abandonment, engulfment, or annihilation concerns, being worried that people will leave you, in other words, that they'll take away your identity if you get too close to them, or you'll simply cease to exist if they should leave. Counterdependency problems, frequently volunteering to help other people, and undue dependency or masochism, which is the flip side of being counterdependent. Now, the symptoms that resolve the most rapidly are those reflecting core areas of impulsivity, for example, self-harm, suicide efforts, as I mentioned before, and active attempts to manage interpersonal difficulties, stormy relationships, devaluation, manipulation, sadism. The reality is the patient who's most action-oriented and most engaging, but perhaps in a stressful way, may well stand the best chance of getting well. The most stable symptoms in the affective realm, they reflect areas of chronic dysphoria, anger, loneliness, emptiness, it just doesn't go away. Interpersonal symptoms reflecting abandonment and dependency issues, for example, intolerance of aloneness, counterdependency problems. And these symptoms, while easier for therapists and family members to tolerate, actually may signal a worrisome sign for overall course of disorder. Now, what's recovery from BPD? Recovery is a far more complicated and I think more important outcome in many ways than remission. Recovery is defined as having a concurrent remission from BPD and good social and good vocational functioning. This psychosocial functioning is defined as at least one emotionally sustaining relationship with a friend or romantic partner, not a biological relative, and a good vocational performance, a sustained vocational history, and full-time vocational engagement. So it's pretty much what most of us would think for ourselves. We have some people in our lives who we get along with, and we're able to earn an income or take care of our families competently. Now, recovery is more difficult to attain than symptomatic remission, particularly sustained recoveries lasting 4 through 8 years. 60% of borderline patients achieve a 2-year recovery, 54% achieve a 4-year recovery, 44% achieve a 6-year recovery, and 40% achieve an 8-year recovery. Now, loss of recovery is somewhat more common than symptomatic recurrences. After recoveries lasting 2 years, about 44% of people lose their recovery. After recoveries lasting 4 years, 32% do. After recoveries lasting 6 years, about a quarter. And after recoveries lasting 8 years, about 1 in 5 people. So obviously, the longer you're recovered, the more likely you are to hold on to your recovery. And what are the reasons for difficulty attaining or maintaining recovery? And nobody of us recovered at baseline. Inability to work or go to school consistently and competently on a full-time basis. And in fact, at this time point in the study, a 16-year follow-up, 47% of the people are on disability and not working or going to school. So what we're finding as we study these people out over time, and we started to analyze 18 and 20-year data as well, is that these groups pretty much are stable. That even in 20 years, not only, but 60% of borderline patients have fully recovered, while 40% have not. And what about our comparison subjects who also have some form of personality disorder and who were also McLean inpatients all these years ago? They have more stable rates of symptomatic remission. 99%, just like borderline patients, have a 2-year remission, but 97% have an 8-year remission, so there's almost no drop-off in over time. And they have higher and more stable rates of recovery. 85% have a 2-year recovery, not the 60% of borderline patients, and fully 75% have an 8-year recovery. So even though clinicians couldn't discern which group these people were in at baseline, and why should they have been able to, they only had the patient for 6 days, still, this is a remarkable difference. Now let's talk about prediction of time to recovery from borderline personality disorder. The multivariate, which simply means together at the same time, predictors of time to recovery are never having been hospitalized before the index admission, having a good vocational history before you came into the hospital in the 2 years before that, having a higher IQ, although not necessarily a high IQ, having no anxious cluster personality disorder. In other words, you have few avoidant and few dependent traits. You have higher trait extroversion, which doesn't just mean being outgoing, it also means you have positive emotions. And higher trait agreeableness, which is not just you agree with people, it means also that you have compassion for other people. So, whoops. Now the nature of these significant predictors, lack of chronicity, no prior hospitalizations, competence, good vocational history, and a higher IQ, and temperament, which seems to be the most important thing, lower avoidance, and higher positive emotion and compassion for others. And non-significant predictors, interestingly, are childhood adversity, sexual abuse, severity of other forms of abuse, severity of neglect, adult adversity, physical and/or sexual assault, family history of psychiatric disorder, and access to psychopathology. So everything that clinicians often believe are the predictors of recovery, in fact, aren't. It's not so much what happened to you or what didn't happen for you as a child or an adult, or what runs in your family, or what axis 1 disorders you have. It's really basically your natural endowment and your temperament. And there is help for temperamental problems. It only takes looking a little bit to the left or the right to see the world in an entirely different way. Now, psychiatric treatment. Most of these people were treated in the community. They were mostly treated by psychologists and social workers for psychotherapy, by psychiatrists, or more commonly, as time went on, their PCP for medication. As I mentioned before, almost none of these people had any kind of evidence-based treatment. About 70% of patients with BPD are in individual therapy and taking standing medications during all 8 follow-up periods. However, the rate of psychiatric hospitalization declined from 100% at baseline to 24% at 16-year follow-up. What the data looks like is that there's a decline from baseline to 8-year follow-up, and then from 8-year follow-up to 16. It sort of levels off. But it looks like these people need or want to be in a non-intensive outpatient treatment for a sustained period of time. Now, rehabilitation model. Some borderline patients may need to be treated with such a model, as they have difficulty working consistently and confidently. They have trouble managing everyday tasks. They often back away from anxiety-provoking situations, including the social realm, and they struggle with sleep and pain management. Now let's look at polypharmacy at 16-year follow-up. Borderline patients, on average, I believe, take more medications than people with schizophrenia, even though there are no FDA-approved medications indicated for this disorder. About 40% of borderline patients take 3 or more psychotropic medications. About 20% take 4 or more, and this is a 16-year follow-up. And about 10% take 5 or more. And as I think a slide will come up to indicate, this has really negative impacts on people's health. Now, polypharmacy and borderline personality disorder. There's absolutely no empirical evidence of its efficacy. Our group's the only one that's ever studied polypharmacy versus monotherapy, multiple drugs versus one, finding that they're both equal in terms of their efficacy. Polypharmacy is associated with high rates of obesity. Over 30% of the patients in this subject, almost all of whom were normal weight at baseline, are now obese. And the obesity came on quickly and did seem strongly related to the medications. Now, this obesity, in turn, is associated with elevated rates of osteoarthritis, diabetes, hypertension, chronic back pain, urinary incontinence, GERD, and gallstones. And at 16-year, people are in their early 40s. Now, other health findings: non-recovered borderline patients are in worse physical health. 37% versus 16% of recovered borderline patients had a poorly understood syndrome such as fibromyalgia, chronic fatigue, or TMJ. They're more likely to make poor health-related lifestyle choices. 34% versus 16% are smoking a pack of cigarettes a day, which has led to elevated rates of COPD. And they use costly forms of medical care. 40% versus 17% had a medical hospitalization. Now, suicide and other deaths. At this point, 5.2% of borderline patients, so moving from 16-year all the way out to 20-year, of borderline patients have committed suicide after 22 years of partially complete follow-up. and 6.9% have died of natural causes or accidents over the course of the study to date. And the natural causes tend to be obesity-related or smoking-related. However, only one comparison subject has committed suicide and 2 others have died of other causes, not related, interestingly enough, to smoking or being overweight. Now, the main findings, just to review, and then I'll be open to your questions. 99% of patients with BPD experience a remission of their BPD. Recurrences of BPD are relatively rare. As I mentioned before, the course of BPD is very different from that of mood disorders, where remission occurs more rapidly, but recurrence is more common. And BPD does have the best symptomatic prognosis of any of the major psychiatric illnesses. That information doesn't get out there very much, but it's true. BPD seems to be comprised of 2 types of symptoms: acute symptoms and temperamental symptoms. All of the 5 empirically based treatments for BPD aim at the acute symptoms of BPD, particularly self-harm and suicide, and don't, I think, focus very much on the temperamental symptoms, but it may be the temperamental symptoms that are the actual drag on reaching recovery. Recovery from BPD is more difficult to attain than remission from BPD alone. However, it's relatively stable once attained, and the difficulty seems to be in people not so much being able to hold on to a full-time job, but being so nervous and upset and overwhelmed that their treatment team feels they would be better off not working. Completed suicide is substantially less common than the expected 10%, although a colleague of mine pointed out at a recent conference that 5 or 6% is still an awful lot of people to be committing suicide. However, this lower rate may be due to more trauma-sensitive or supportive treatments. And prediction of time to recovery is multifactorial in nature, involves factors that are routinely assessed in treatment, such as childhood adversity, and other factors, particularly aspects of temperament that are not. They're noticed by clinicians, but they don't seem to be discussed or particularly addressed psychotherapeutically. And in conclusion, the symptomatic course, particularly for acute symptoms, is substantially better than previously known. Other areas such as vocational functioning and physical health have a more guarded outcome, but the more guarded outcome is only for the non-recovered patients. For the recovered patients, they really look very much like the comparison subjects. And treatments of proven efficacy have been developed for BPD, but are not widely available to people without significant resources who live in certain specific areas of the U.S. So I'd be glad to take your questions now.
So thank you, Dr. Zanarini. That was a really great presentation, and we already have a lot of good questions. A couple of people have asked specifically about your study. So the first one that I'll pose to you is, can you tell us whether you identified any factors in terms of treatment related to the people with BPD who had better outcomes? So are there any specific types of treatment or engagement in any program that seem to be associated with better outcomes that you were able to observe?
Because this is a naturalistic study, I really could not assess the effect of treatment. However, my personal opinion is that people who do best, who have therapists who are really dedicated to keeping them functioning as best as they can and improving that functioning. They're not particularly focused on the past or people's histories, although they certainly take a history. They certainly respect any reports of adversity, but that they're throwing all of their psychotherapeutic weight behind trying to get the person to stay at work, trying to get them to keep their friends, trying to get them to start to date. And those kinds of therapists, I think, just by my observations, their patients tend to do better.
I think that's a really great point, and somebody specifically asked about that. So I'm wondering if you can even elaborate on that. What types of treatments or therapists seem to be correlated with improved vocational or psychosocial functioning? How would a family member be able to identify a therapist who can do exactly what you said, who can encourage them, support them, stay focused on functioning as opposed to their miserable past?
Well, one of the ways to think about it is that therapy can be seen as a lifestyle or an adjunct to life. If someone wants to engage you or your family member in a remarkably intensive treatment and wants to talk about everything that went on in the past and understand every single thing, I would be concerned. I think the person who sees a patient once and most twice a week is totally, as I mentioned, focused on helping them be adaptive, move forward, and has great confidence in their ability to do so and displays that confidence. I think the kinds of therapists I would worry about are the therapists who see these people as victims of somebody. Because if you start to see yourself as a victim, then I think you don't have much of a sense of agency. You're simply waiting. Somebody made you sick, so you're waiting for somebody to make you well. And the reality is that people who do best not only have therapists with fighting spirits, but who themselves identify with that fighting spirit and struggle day in and day out, month in and month out, year in and year out, to get the life that they originally planned for themselves. They can do that with help, but the therapist has to be devoted to that. They have to see therapy as adjunct to life, not as a lifestyle.
And so what would you say to a family member who feels like let's take a daughter, who feels like their daughter is in therapy with somebody who seems to kind of be complicit with their victim role? And as far as you can tell, the daughter's not making progress. She's constantly complaining about being a victim. She's constantly making excuses about why she can't work, why she doesn't have friends, because people aren't trustworthy, because she's too ill, because her symptoms are really overwhelming, and she can't possibly be expected to do the things that the family members are constantly asking her to do. And the therapist seems to kind of go along with that, and the rare communication that the family has had with the therapist seems to suggest that the therapist believes, yeah, she's really sick. You're asking a lot. What do you mean? Get her job. What are you talking about? This is a really serious illness. What would you suggest? And I want to say, as a practicing psychiatrist who's worked with a lot of patients with BPD, I 100% endorse what you've said. Because I think all too often it's actually the therapist or the therapeutic program that can make the fundamental difference in the mindset of the patient. The therapist can either say, I know you've had a rough life, I get it, you had a really tough time, it's been awful, but you can get better. I know you can get better. I want you to get better. And if you're not getting better, I'm even going to wonder whether I should keep working with you, because if you're not getting better, then I must not be helping you. I must not be a very effective therapist. And so the therapist may almost threaten abandonment if the patient doesn't get better and show some progress. Whereas other therapists will, again, collude with the victim role. So any advice for family members who feel like their daughter or son or loved one is kind of stuck in a therapeutic relationship that maybe isn't ideal?
Well, that's a very complicated question.
And you've got an easy answer, don't you?
But one of the things I do to try to get as much information as I can is I see all of my patients' families once a month. And everything is out in the open. Everybody's hearing the same things. Everybody can talk in front of the other people. I learned so much from family members, often how they've been suffering. And I would say if you have and I'm seeing adults, not children. So these people can be in their 20s, 30s, even in their 40s, and still their family members come in. And if you have a therapist who simply won't tell you anything, I would be somewhat concerned. But at least you can encourage your loved one to seek out a consultation with someone who's really an expert in this area. Because finding the right therapist, and there's no way that these therapists who see people more as victims are being deliberately unhelpful. They simply have a different understanding of BPD than apparently Chris and I do. But the reality is, I firmly believe that just as our parents gave us a push out the door, these people needed too. And encouraging people, even pushing people to perform better, doesn't mean abandonment. It often strengthens and makes the therapeutic relationship warmer and more vibrant, because people are happier and can come back and report triumphs, not yet again another failure.
And I would actually want to second that. And I have to say that I've kind of threatened abandonment, told patients that I might have to stop working with them if they don't get better. And why? Because I feel like I'm not helping them, and I really care about them, and I want them to get better. And if they're recurrently self-injurious and in and out of hospitals and not functioning, then clearly I'm failing as a therapist, and I would say that to them. And I think almost universally they knew that was true. And so they never did feel abandoned. They actually felt empowered by it. And even if skeptical or afraid, they were afraid they may not be able to live up to my hopes or expectations, I think they usually were more hopeful that somebody believed in them and somebody actually authentically cared about how they were doing and functioning. Another person asks a slightly related question. So what if a daughter is in treatment and getting somewhat better? How do you know if it's good enough? How do you decide, should we look for a consultation? Should we leave it alone because there's very slow, gradual improvement? Maybe this is as good as it gets. Somebody specifically asked that.
I think if your daughter has stopped self-harming, stopped threatening suicide or making suicide attempts or getting hospitalized, that's a really good marker that the person's making appropriate progress. Because until those things occur, it's very hard for someone to hold a job or go to school. It may even be hard to have friends. And it may also be hard to have a romantic life as well.
Okay. So moving on to some other topics. Do you have any suggestions about the weight gain from medications? One person notes that her daughter has gained about 100 pounds since being on medications, and you spoke about this in your slides. Any suggestions on what patients or families can do to try to counteract that?
I think what's happened is that a lot of psychopharmacologists have started to give one medication per sector of borderline psychopathology, so you have at least 4 meds. The typical person who was an inpatient with BPD is taking an antipsychotic, an anxiolytic, an antidepressant, an anticonvulsant, possibly a stimulant, which will obviously not lead to weight gain, nor will an anxiolytic. But you really have to ask yourself, what are these medications doing for me, the patient, or doing for my child? Because many of these people mistakenly carry a bipolar diagnosis. Mark Zimmerman from Brown did a very important study that showed that almost 100% of borderline patients in his outpatient clinic at some point or another had received the bipolar 1 or 2 diagnosis, even though he couldn't find but a few who actually, according to his team, met lifetime criteria for bipolar disorder. So if you need to ask the doctor, what is being medicated? My child's borderline symptoms, a comorbid disorder, what is that comorbid disorder? What's the evidence that they have that? Because, and I'm not sure people realize this, but weight gain through medication use, aggressive polypharmacy, is harder to get off than something gained through overeating, because your metabolism may have actually changed. And we have people now, one woman actually had a BMI of over 70, and people literally are dying at a much more rapid rate now in the study than before. And I'm receiving, just this week, 3 additional people have died due to weight-related or smoking-related causes, and these are unnecessary deaths. I don't think therapists are aggressive enough in tracking what the patients are taking. You're seeing the patient far more often than a psychopharmacologist. And psychopharmacologists may want to think about that you're trying to medicate away possible suicidality when they're young, but their life is going to be shortened possibly if they gain all this extra weight. There has to be a balance between safety and respect for the integrity of someone's physical health.
Okay. The next question comes from at least 3 different people, and we've had this question a lot in past webinars. And the question is about, how do you help a loved one get help, find a therapist, work with a therapist who is in denial and doesn't think she or he has problems, or well, let me stop there. So somebody who says they don't have problems, yet is constantly complaining about all the problems, and you see all of the overt signs of borderline personality disorder, the turbulence in relationships, the self-injury, the kind of emotional lability. Any suggestions for family members about how to be more effective in trying to persuade them to seek help?
It's a very difficult topic. I think all you can do is say, you're suffering so much, it's hard for me to watch this and do nothing. I really think we need to make an appointment for both of us, because what's happening to you is happening to me in a way too. Let's go together, and you can talk to the doctor, and then I'll talk to the doctor, just as we would if you were suffering from the virus. This is not a commitment to long-term psychotherapy. I'm not trying to trick you to send you to a hospital. You're not a bad person, but you are suffering. And I really think we absolutely must do this as a family.
Good. The next question, a few people have asked about the complications of romantic relationships in people with BPD. Some people have said that it seems like romantic relationships maybe complicate a life that's already struggling to improve. Another person notes all the boyfriends seem to have more problems than she has. Another person just notes that although her son with BPD is lonely and seems to be desperate for a relationship, once he's in it, it leads to lots of drama and turbulence. So any thoughts about the complications of romantic love?
One thing we've noticed is that the people who married young and had their children while young, while they were still sick, have done far worse than the people who focused on getting well, focused on getting an education, and put off marriage and put off having children. And those marriages have been pretty stable. Obviously, some people have gotten a divorce. But the people who really waited and put off a lot of intensity in that aspect of their life did far better. Because to have a really full-blown romance and be dealing with a serious illness at the same time is hard going. And although I'd like to say that I think a wonderful spouse actually can help stabilize someone. Not everybody gets a wonderful spouse.
Another person asks about their 18-year-old daughter who is quote-unquote self-medicating with marijuana most days. Although the daughter seems to suggest this is helpful, the mother is very worried that this might be interfering with brain development, frontal lobe development, and will this maybe have an adverse effect on her ultimate recovery?
Skip Popa, an investigator right here at McLean Hospital, has found that long-term marijuana use can impair people's cognitive functioning. But it's hard to convince young people that that's true. I've had many patients tell me that smoking marijuana now and again, or more than now and again, has helped them, particularly with not feeling so angry. I personally am of the position that life is painful, and we often have painful feelings, and racing to get rid of them either through medication or marijuana or anything else sort of denies some of the true contours of adult life, which is bad things happen, it hurts, and we can't actually bear those feelings. But now that marijuana is legal for medical reasons and soon will probably be legal for any reason, I think it's going to be really hard to stop the inflow of people smoking. But I don't necessarily think it's a gateway drug to substance abuse. I think some people have a real genetic loading for substance abuse and some people don't, and will just stay at the level of marijuana, just as if they'll stay at the level of a beer, not drinking a six-pack a night.
Okay. Another person asks if you have any suggestions for specific types of support that are helpful for family members. So if you're a family member with a child or loved one with BPD, any advice for specific types of support for those people, just in dealing with the drama, the chaos, the ups and downs, the complaining.
Perry Hoffman runs an organization called NEA BPD, and she's a treatment that's taught by peers. It's for parents and spouses. And they not only learn a version of DBT, they learn some of the skills that therapists who are DBT treaters have, but they actually really support one another tremendously in and outside the group. And I took that training, and I was amazed that the last half an hour, people were asked to say how they felt, and one family got up and one woman said, "I think my daughter will be dead in a year." Another person got up, he said, "I think my son will murder my wife or me within a year." And they got tremendous support from the group that, in fact, these things might happen. They weren't imagining them or exaggerating them. So if you can find one of these groups run by NEA BPD, get involved, take the training, and stay involved with a group of parents or spouses suffering as you are, I think that'll be the best thing for you.
Okay. So another person commented that she has a daughter who's 21 and very gifted academically. She's doing well in college, but has no true friends and has basically cut ties with all of her family except for demanding financial support. This person's own psychologist, as well as her husband and other children, are urging her to cut contact with the daughter because of the way she treats me. But I know she's ill, and it feels wrong not to reach out to her. She's refusing treatment altogether because she doesn't believe she's ill. Any advice for this clearly loving mother about what might be most helpful?
I think it's very hard for parents to cut their children off, particularly when BPD is involved, because your child is both so attached and can be so dismissive at the same time. Again, I would suggest joining something like NEA BPD for training and for support, because this will go on for a long time, and there'll be senior parents there who've been through what you've been through and are out the other end, but they still stay involved because it's so useful to them. And I think you have to do what's right for you and not be pushed by family members to do what they think is right or they read in a book somewhere. If you feel it's wrong there's got to be a way to be involved with someone where you're not a punching bag, but you haven't abandoned them either.
All right.
So with that, it is 5 o'clock, and we are going to have to end tonight's webinar. Thank you so much, Dr. Zanarini. This was extraordinarily helpful, and your information is helpful. Again, I want to remind viewers that this webinar will be posted on our website in probably a few days, but if you missed any of our other webinars, they are all posted on our website, and we've got an upcoming webinar March 2nd with Dr. Michael Hollander. You should see the screen for registration right now, and you can feel free to register for that currently. And with that, I will say good night to all of you, and thank you to Dr. Zanarini.